All right. Well, I want to take this opportunity to thank everyone for joining us at this year's Research Opportunities Workshop. This is the second year we've done this, and we get to use this beautiful venue. And thank you for everybody who came in person. The food is fantastic. And I really want to thank Rose Darrington, who's our assistant, who really set this whole thing up for us and made all of this happen. So without Rose, this would have been not the event that it is today. And thank you very much, Rose. So I'm going to talk a little bit about radiology research, and then I'm going to go into a little bit of Bill Colantoni's ED department because he's got to work tonight, and I may let him take over and speak from his Zoom, and then George is going to do his presentation before he goes saves lives tonight. Okay. Well, let me run through this quickly. This is our publication list. It's actually about 256 because I made a mistake on the formula, but we published more papers last year than any year in the last 4. And it's really highly productive, a lot of first authored papers as well. So these are brief presentations from the faculty. They should all have contact information for the faculty on the slides. This presentation is going to be recorded and placed on the radiology website, so all of your colleagues in the medical school can go to it and see this, and probably even see last year's presentation and reach out to people to work with them to do projects. So this is Bill, this is your stuff. Do you want me to just run through it, or can you hear me okay?
I can hear you. You could run through it, it would be great. I actually don't have access.
Through it real quick. All right, so there's 5 projects that the emergency radiologists who work nights a lot of the time have going on. They're really interested in looking at CT perfusion imaging for stroke workups. The idea being that if there isn't a large vessel occlusion, can CT perfusion find a stroke that should be intervened on medically? There's a retrospective review of non-accidental trauma in elderly, which is far too common, and trying to figure out what's going on with that in the community. Review of the use of CT for trauma in pregnant women. How do we do the dose properly? How do you image properly in a pregnant woman if you have a trauma that's going on? Pitfalls of CT imaging in the obese patient. Sometimes there's a lot of artifacts in an obese patient, and if you have a trauma, there can be artifacts that you want to look at there. And then there's an artificial intelligence set of software to detect pulmonary emboli to sort of activate the PERT teams. We've looked at a couple of them from the IR perspective. And the question is, how accurate are they? Do they help in getting patients in for thrombolytic therapy or suction embolectomy faster? So this is our presentations. George, do you want to present this? All right, come on up.
Thanks, Gordon. Sorry I couldn't do that.
Yeah, no, it's great. If you want to stand at the podium, the mic's good. Forward, back, and there's a pointer.
Hello, everyone. I'm George Lachenko, one of the attendings here in IR. I mainly work at Highlands Ranch Hospital, which I actually should go there in a few minutes to do a postpartum hemorrhage. So I'm going to go through this pretty quick. It's a simple but important topic. It's about chest port complications. So these are just a rundown of some general, more common complications. I mean, they're not common, but there's probably other ones in here that I didn't list, but ones that we have seen. So infection is number 1. The data is all over the place with how the rate of incidence of infection with chest port placement. So I'm not going to quote any numbers, but it's pretty small in the single digits. There are some papers that showed it in the double digits, but I think those are outliers. Port dehiscence, hematoma, seroma, catheter-associated thrombus, port malfunction, and catheter fracture. We see a lot of catheter fracture with subclavian ports that are usually placed by the surgeons, and often it's pinch-off syndrome. The subclavian goes between the first rib and the clavicle, so gets rubbed on and after time can fracture. So what I thought would be interesting to look at was infections complications. They are kind of a big deal. We are tracked on them, and the hospital, you don't want to have any catheter line associated infections. So they are looked at pretty closely, and they make a difference in the patient's care, because then I'll take the port out and maybe get a PICC and delay chemo and things like that. So I was thinking, is there a difference in infection rates between an APP attending in a resident placing the chest supports? And could there be a difference between institutions, even though we have the same attendings? Is there any difference? Because the environment can also contribute to infection. Each place has different flora and different ventilation and various infection control processes. So these are a couple ideas I had. And then the same thing with port dehiscence. Is there different suturing, with between attending resident and APP? We all have different styles. We all have different experience, and these kind of two. We see them more common in the other complications. So I thought this could be something to look at.
All right. Any questions for George before he leaves and saves lives? All right. Have a good night, George. All right. So next up, we've got field brain MRI. Are you on? I think
Yes.
this is, go ahead. I can advance the slides for you. So
thank you very much. So thank you very much for inviting us to describe our project with the title of fetal brain MRI at altitude. We know that at altitude we have about 15 to 20% less oxygen, and we would like to investigate the impact of that on fetal brain development compared to the sea level. On top of that, we know that fetuses with congenital heart disease also have some problems to have a normal blood flow circulation in the brain. That also hinders the fetal brain development. So we're going to investigate whether the primary effect of altitude and the secondary effect of congenital heart disease would hinder the fetal brain development. And that's our hypothesis. In fetuses with congenital heart disease at altitude, is there a correlation between the expected pattern of in utero brain blood supply and the severity of neurodevelopmental impairment? We're going to measure the severity of neurodevelopmental impairment by measuring the brain volume and do brain volumetry to calculate the total brain volume and also the regional brain volume. So can we go next slide, please?
Yep, is this good?
Yes. So to investigate the effect of altitude, we have identified, to investigate the effect of altitude on the brain development of fetuses, we have identified 222 fetuses with normal brain at altitude. We have also collected 80 fetuses with normal brain at sea level from University of California in San Francisco. And then we are going to perform brain volumetry, and then we're going to compare the total brain volume and also regional brain volume between these two cohorts. And actually that shows us the effect of the altitude or less oxygen at altitude compared to the sea level. Thanks, Gordon. Can you go to the next slide, please? Then to investigate how congenital heart disease would also affect the fetal brain development, and to see whether there is a delay in the fetal brain development of fetuses with congenital heart disease, we also identify 100 fetuses with congenital heart disease at altitude. We have also identified 100 fetuses with congenital heart disease at sea level, and then we're going to perform brain volumetry again, and we're going to compare the total volume and regional brain volumes between these two cohorts. And then that's going to answer our question, whether how much of the reduction we're going to see due to the altitude and how much of the reduction we're going to see due to the congenital heart disease in the fetal brain development. To do the brain volumes, to perform the fetal brain volumetry and calculate the fetal brain volumes, we're going to use MRI. Clinically, these images go under MRI to look at their brain. They usually acquire multiple stacks of 2D images in axial, coronal, and sagittal view. We're going to collect those. We're going to put those images together. Can we go to next slide, please? Thank you, Gordon. To generate a high-resolution 3D image of fetal brain. And that's a place we need the help from the medical students to perform a segmentation to delineate the fetal brain into 7 structures. Can we go to the next step, the next slide, please? Thank you. So we're gonna look at the white matter, grain matter. We're gonna look at the cerebellum. So, and left ventricle, right ventricle, and third and fourth ventricle. So we need help to manually segment these fetal brain into 7 substructures. The manual segmentation is time consuming. It's 3 to 4 hours for one case, but we need help to develop an artificial intelligence-based segmentation algorithm to do the delineation automatically. So that's a place we need the help from. If you are, can we go to the next slide? Thank you very much. If you are interested in this project, please feel free either to contact me or Dr. David Mirsky or Dr. Paul Pollack. Thank you very much, Gordon.
All right, thanks a lot there, Mehdi. So the opportunity for you to really engage in fetal brain measurements and get some projects related to neuroimaging in kids.
If I may, I just want to add that we're going to appreciate your help by having you as a co-author in any resulting manuscript that come up from this study. Thanks. I'm done.
Great. So next I have Chelsea Life's going to present the work with Dr. Hayes and Dr. Miller.
Hello. Hi, everyone. Thank you so much for this opportunity. So as was previously mentioned, I'm Chelsea. I'm one of the second-year radiology residents. I'm speaking on behalf of my group, which includes my PIs, Drs. Carrie Hayes and Sarah Mia, both pioneers in the field of pediatric radiology. So the goal of our project is to establish normal values for pediatric esophageal diameter. This is very important because, as I'm sure you all know, that as children grow, the esophagus changes with them. But we don't really have great literature on establishing what the normal values are as children age, and this can be helpful for diagnosing conditions such as eosinophilic esophagitis. So as a result, we are working on conducting a chart review among patients without any esophageal pathology. We're going to be measuring the esophageal diameter on upper GI fluoroscopic studies. And then we can use these values, these measurements that we take of the esophagus at several different points. And then we can use them categorized by age to establish what these normal values should be for each subpopulation that radiologists going forward can use as a reference. So where medical students can help in playing a role in this is this chart review will extrapolate, or rather gather data for these patients, including the age, weight, sex, and several other factors, because we hope to create a large data set that will show, based on weight, age, height, etc., we can correlate those with the expected value for esophageal diameter. I have my phone number here. You can feel free to reach out to me via phone, or my email address is also listed here if you're interested in participating in our project. We'd love to have your help.
Great, thanks, Chelsea. Again, an opportunity to get involved in some retrospective research. These are great papers and abstracts for medical students. So encourage you to reach out to Chelsea if you want to help out. All right, the IQ lab. Is this Julio? Or, Okay. Is he coming later? We can come back to it then. All right. All right, Bennett, come on up. Here, use mine.
Okay, thank you. So thanks for coming and listening to our presentations. I'm from nuclear medicine. This is molecular imaging and targeted therapy and oncology. So in nuclear medicine, we have ligands. They target specific receptors on cells, and we image them with PET agents. And we use the same targeting ligand to deliver radiation therapy to tumors. So that's one of our big areas. We're working in two major areas: prostate cancer. We have a ligand called prostate-specific membrane antigen, PSMA. It targets the cell surface receptors and basically hones in. It's kind of like a target. And it has very high affinity for these prostate cancer cells. And so we can image them with PET, and we can also deliver targeted radiation therapy. We have a PET CT, and we also have a brand new PET, and that's one of the very few imaging instruments in the country. So it's a great opportunity to learn about PET MR. We also have special targeting agents for neuroendocrine tumors. We have a targeting agent called dotatate, and this specifically goes to somatostatin receptors on neuroendocrine tumors, and it has very high affinity, so we can see things that other modalities can't. So that's true for both prostate cancer with PSMA, as well as neuroendocrine tumors with dotatate. And these are recently FDA approved, so we use these in the clinic. So these are very brand new therapies, and these are the areas that we work in clinically for research. So what do? We use artificial intelligence and deep learning to basically translate our ideas into something that's automated. And so right now what we're working on is automated lesion detection and quantification. Now, a very ambitious project with a long-term goal of this is to augment the ability of the reader to make them faster, better, more accurate, and quantitative. And that's important because our colleagues in oncology need to know how their therapies are working. And if you quantify that and give them a very reliable, reproducible tumor volume or tumor activity, that changes patient management. So that's really why we want to do it. The goal eventually is to cut our work in half or less than half, cut it down by up to 80, 90%, so that it's really fast, it's really accurate, and eventually it really helps patient care. So we're working on automated lesion detection and quantification. There are many ways to do this, so I think that's a great opportunity for someone with a lot of imagination, and hopefully someone with some background in computer science, physics, to help us out with that. So we're using AI for automated detection, lesion measurement. We're specifically looking for someone with experience in Python to do this project. It's segmentation and whole body quantification in PET CT. This is one of the papers we published last year. The first author here was a medical student, and he's now a resident. A very bright guy who did many things that, let's say, we didn't really have the technical expertise to do at the time, but we knew exactly what we wanted. So we also have clinical projects in physics. We're working on lesion detectability, small lesion detectability, and we're also looking at other metrics of detectability, like signal noise ratio and quantitative measurements of lesion detection. We have a great physicist working with us. He's published a number of papers, and I'm sure that he would think of many things for other people to work on as well. And finally, we do write a few review articles. It's a great way for our trainees to get experience and in-depth knowledge of what we do in nuclear medicine. So here's a couple of papers that we wrote for review articles. So those are the three areas we work in nuclear medicine: AI and lesion detection, clinical physics, and we do a few review articles as well. Okay, thank you.
I'm going to go back to Julio's presentation because he's on now. And I'll run through this quickly because I have them all in order. There you go, Julio, go ahead. Are you muted? Any word, Rose?
Hello, sorry. Can you hear me now?
There you go. We can hear you now.
Okay, sorry, my computer was doing something crazy. Okay, sorry about that. Yeah, so sorry, I didn't kind of follow this time the guidelines of summarizing one project and what was needed in that project from you. I decided to actually show you a little bit what imaging modalities we use, parameters we measure, techniques we use, the study populations we have, so you can probably think on a project that you would like to do and come and talk to me and we'll find a way to get it done. So basically in my lab, I call it the image quantification lab, we are basically a musculoskeletal imaging group that we are dedicated, as you can see there, to the development and implementation of novel image analysis algorithms, mainly for the identification and quantification of relevant features in medical images for musculoskeletal assessments. Most of the projects at this moment are focused on bone fragility, and bone fragility using mainly 3 imaging modalities, as you can see here. We use MRI, we use QCT, and we use a new, relatively new imaging modality that is called high resolution peripheral quantitative computed tomography, or HRPQCT. We just got that machine installed, is running. We just got the first participants of studies this month, actually. Is in the Anschutz Health Science Building. And as you can see here on the right side, it basically is an imaging modality that enables you to generate images of the distal radius and distal tibia with very small voxel sizes in the order of 61 microns. So you can actually see the trabecular bone. You can differentiate between cortical and trabecular bone, and you can quantify different aspects of bone microarchitecture, in addition to bone mineral density, with very low radiation dose, so under 5 microsieverts per anatomical site per acquisition. And you can actually then use it also in pediatric populations. What we measure, which anatomical regions we use predominantly, we image the proximal femur, the lumbar spine, and as I just mentioned, with these imaging modalities exclusively designed for the distal radius and distal tibia. Why the proximal femur and lumbar spine? Because those are the sites that are most interesting for us for bone fragility. What we measure with MRI, we measure bone marrow fat. We also measure shape of the bone, and the idea is with all these imaging modalities get some parameters that can help us to estimate bone strength. With QCT, as you would expect, we measure bone mineral density, we measure shape, and also we can actually, in collaboration with the mechanical engineering department, we can perform finite element analysis to get estimates of bone strength. And then with HRPQCT, you get volumetric BMD, you get bone microstructure, you get shape, and we also can perform microfinite element analysis to get estimates of bone strength. What techniques we use? Segmentation, feature extraction, correlation, classification, and prediction. Using, obviously, we can use machine learning, and we are going to get a new postdoc to do deep learning too. What the study populations? We are starting a type 1 diabetes study, so probably this study, if you are interested in type 1 diabetes, would be good to wait a year or so to start getting data. We have an ongoing project of the response of bone to exercise and DHEA. We are involved in a project involving weight loss. We have data of HIV. We have data for HRPQCT for sex differences. We have data for osteoporosis treatment. That project hasn't started. We have the data. We haven't started to analyze that with HRPQCT. And also, if you are interested in this project of renal diseases, we still have to wait because it's just a project that is just starting. So again, if you are interested in musculoskeletal imaging, if you are interested in any of these imaging modalities, if you are interested in any of these parameters or exploring some of these imaging techniques, please approach to me and we can talk about it and find a good project for you. And that's it.
Great, thanks, Julio. So this is one of our PhD researchers in the radiology department. So very high-end, bone density, bone analysis work, and an opportunity for medical students to learn something about orthopedic imaging and what the science is around it. So thank you very much, Julio.
Thank you.
And I think as we go forward through Bennett's great presentation, so you get to see it twice. Let's go on to Lisa. You're the last one tonight, Lisa.
You're muted, Lisa.
Yeah,
Thank you.
there you go.
Yeah, you guys can hear me now?
Dr. Walker, one of the IR faculty. Go ahead. I'll advance for you. Just let me know.
Thank you. So for my first project, it's about port placement and tunnel line placement. So the guidelines are not, there's no consensus on if we give antibiotics before or not. And currently we give antibiotics before all ports and all tunnel lines. So I already have a prior large database that shows that there's no difference in infection. It's like 100,000 patients, but it's a large database. So it's not really patient level data. It's not really single institution. So I thought it'd be a good opportunity to start that here. So we are giving antibiotics and we have all the data of infection rates pretty well documented. And I want to change the practice now so that we don't give antibiotics, and then we'll follow that and see what the rates of infection are. And so that's a pretty simple one. I have a paper that's pretty much already written on that too.
Great.
And then next slide. And then my second one is for hypersplenism. We commonly do splenic artery embolizations, and the most common thing that we use for embolization is particles, which can be very painful for patients. Some patients just would rather prefer to have a splenectomy because you get really, really strong tissue ischemia. But there are a few case reports where people use onyx, and onyx can give you the embolization that you need, but it's also better tolerated by patients. But there are really only few case reports, small sample size. So we've started doing that here, and patients have been tolerating that really well and discharging the same day. So I think it'd be nice to have a larger study just to follow these patients. And I want to compare the pain response, see if they discharge the same day, and then also see the platelet response. And then next.
There you go.
And then my last one is for pelvic venous disorder, is commonly known as pelvic congestion. So you'll read in the books that it's varied. People will do bilateral gonadal embolization and then maybe do an internal iliac vein sclerotherapy if they have persistence. Or some people will even just do left gonadal vein embolization and just see. I've been doing bilateral gonadal vein embolization with coils and sclerotherapy. And then I've also been doing internal iliac vein sclerotherapy in the first session. And I haven't had a patient come back without resolution of their symptoms. So I want to test this out and see if doing the initial treatment in the gonadal veins and the internal iliac veins, if that has a better outcome for patients versus staging it. And then if there are any bad outcomes, which I haven't seen so far.
Okay. So 3 projects, all retrospective, all with data that's readily accessible from our packs to kind of find the data there. And this is an opportunity to learn something about some of the interventional techniques. I've worked with Mike, and there's ways of getting abstracts and grants to go to the SIR annual meeting and things like that. So Lisa's email and phone number are here. Reach out if you want to do a project with her. And I think that is all we have for tonight. So I really appreciate all of the faculty who presented projects and all of the medical students that came tonight. This presentation will be recorded and placed on our website. So any of your colleagues who haven't had a chance to see this can get access to it and can reach out to work with some of the faculty in radiology. We figure this is a nice way of introducing specifically the radiology research to the medical school class. so that you know that there are opportunities to do research with PhDs and physician researchers in the radiology department. We're here to help and help you learn about imaging and imaging sciences. So thank you all for coming.
Thank you.
Appreciate it. All right.